Welcome everybody to this year's EBC meeting, which is partly personal and partly virtual. It's a hybrid meeting. We do have a panel, and we do have moderators, and we do have a virtual panel. This session is about the future, which may be, well, very predictable. And the name of it is Decision-Making Points in Bifurcation PCI, the future role of artificial intelligence. But I could just say that I'm chairing this session with my good colleagues Tom Johnson, who's virtual, and Olivier Darremont, who's sitting in the panel. We have a chat master, which is Marek Ferenc, and for all the virtual participants, it's possible to use the chat. And if you have questions and comments, please send them to Marek, and he will bring them forward for discussion with the audience and with the panel. In the panel, we have Professor Gultierez-Chico, Niels Holm, and Professor Yiannis Chatzizisis. We also have all the participants who giving talks today. Present is Tinen Iles, and virtually we have Bon Kwon Koo from Korea, Maciej Lesiak from Poland, and Tom Johnson, as mentioned. We have Francesco Burzotta, will be present in a moment, but he's also active in the other session. And by having said that, I think we should move forward. The topic is artificial intelligence, and why? Well, in bifurcation treatment, there's tons of situations where you need to take a decision and make a plan, and it would be very nice to be able to forecast. Forecasting is most often based on tons of informations, and basically processed by the human brain, but sometimes there are things that are skipped from the human brain. And just to go through some of the issues we would be discussing today, there is the prediction and forecasting, as I've just pointed out, but the way we actually try to forecast things today is looking into a known data set, trying to evaluate the data set and see if some of the information in that data set actually is capable with a certain precision to predict something in the future. We use logistic regression for that part mostly. This is how most of the scoring systems are used and how we actually evaluate the risk of closing a side branch or processes like that. There is a kind of a dilemma in that, because by using these statistical methods, it's important to know what we're looking for. And that means that we need to have a pre-specified idea of what may be a predictor of something in the future. That means that we were working with known knowns. We could be working with unknown unknowns, but that is a kind of a inventory or process. But what we are not able to is using the unknown unknowns. Things we don't know could have an influence. And in that perspective, there could be a help from artificial intelligence, neural network, and deep learning. And we'll come back to that discussion. So we could also say, as we discussed in another group this morning, that using artificial intelligence, if it works, may give us more information, but we may just be confused on a higher level. So this is one of the issues that we would like to discuss today. This was prediction and forecasting. But there are also other issues that could be extremely good to embark on, and this could be simulation of complex biological systems. If you, for instance, would like to simulate the flow in a coronary artery with a certain heartbeat in a heart of that age with that scar, how many information do we actually need to put into that model to be able to have a running model which actually also is able to manipulate in? For that purpose, supercomputers and artificial intelligence is also really a potential tool that can bring this area very much forward. Again, we have also the use of, face identification by iPhones or a lot of systems. This is actually also artificial intelligence capable of identifying complex informations out of pictures, imaging, running movies, whatever. So again, here we have a tool that can be very useful in evaluating a lot of the imagings we use in medicine and a lot of the moving images from, for instance, echocardiography and so on. Also, data mining in texts, in medical records for diagnosis and prognosis is an area. And of course, also data mining for a broader use. So this is a technique which is useful, it seems, in a lot of areas. But what do we really know about it? I was at the meeting 2 months ago, where one of my colleagues was just saying that when we discuss artificial intelligence, it's just like, well, overviewing two teenagers discussing what it is to have sex. Everybody have a friend who maybe have tried it, and it should be fantastic, and it should be recommendable, but it's very difficult to get started. So I hope we can actually help a bit here. This is the area. This is just a PubMed search from 2010 until 2020, showing the increase in publication that actually combines medicine and artificial intelligence, whatever artificial intelligence modality it is, but not the text word in the headlines. So it's very, very obvious that this is an exploding area. The circles, which is a bit busy and difficult to read, is actually which area is it in, and the red small on top in the middle is actually cardiology, where there is 627 publications are artificial intelligence, mostly within imaging. So, moving forward to this session, what do we need in bifurcation PCI? What do we need in our daily practice? And this is actually the topic of this session. We need evaluation of data, text, numbers, and imaging in a broader context. We need prediction of outcome. It would be nice to know, if we do that, what would happen with that side branch. Can we do that with artificial intelligence? Maybe, maybe not. And we also need forecasting. Having finalized the procedure, it would be very nice to have an idea of what would the course of that patient be, giving the information at the finalization of the procedure. Because then we have a possibility of prevention. It could be DAPT treatment, it could be one of many others. But anyway, this is difficult, and this is actually a very, very simplistic view of artificial intelligence. So there is a signal, and if that signal is there may happen some things in the future. And having said that, I think we should move forward and take the first presentation, which will be of Professor Bon Kwon Koo from Korea, and we'll talk on how to decide when a side branch is significant and where does the new modalities fit into that evaluation.
Thank you, Mr. Chairman. Hi, everyone. I'm B.K. Koo from Seoul National University Hospital, and it's always my great honor and pleasure to participate in European Bifurcation Club. Today, I'm going to talk about how to decide a significant side branch. How can you define a significance of that branch? In some way, it's simple, because if we can define a branch which can cause symptom, myocardial ischemia, electrical instability, LV dysfunction, myocardial infarction, sudden cardiac death, it should be a significant branch like this. However, we know that the clinical relevance of side branch is much less than the main branch. In this study with an intentional 1-minute balloon occlusion, chest pain and ST segment elevation or ischemia occurs only in 40% of the branches, in contrast to 100% of the main branch. So the problem is, for these side branches, we don't have solid criteria for significant branches. Today, I'd like to review the methods developed to identify a significant side branches, from angiographic assessment to the recent developed tools. We are using, most commonly, the vessel size to represents the significance of that branch. However, we know that it's lots of limitations, such as inter and intra-individual variability. And for this kind of significant disease which needs intervention, generally has a diffuse or obstructive lesion, so we cannot measure the diameter. And it's not accurate. So here you're looking to diagonal branches which seems to have a similar size. However, if you see the territory, it's totally different. So it's not accurate, not reliable. So that's the reason why we are trying to make a smarter scoring systems in the cath lab. So almost 10 years ago, SNU score was developed, integrating size, number, and the location of branches. And recently, we also proposed a modified SNU score integrating the additional index, which is a relative dominance among the branches and also between the other vessels. So this can be useful. However, this is not easy to calculate all the scores in the cath lab. So we try to apply a machine learning technique, such as a decision tree, to be used to assess the myocardial territory. So this is the results of this decision tree. So in general, 15% has myocardial mass 10% or more. And the next type is number of branches and circumflex dominance. If the branch is high, if we can calculate the D12 dominances, we can estimate the probability of that vessel, which can supply more than 10%. So this is easy or complex, but the accuracy is quite good, 0.91 with size, and even without size, accuracy is around 0.9. And we can also make this kind of nomogram, which can integrate all this information to estimate the probability. So while we are struggling in the cath lab, so several CT specialists developed a method to calculate the myocardial mass at risk from the CT scan under the name of fractional myocardial mass, CAMS, and MR. So all this looks fancy, but requires a CT scan, and which should be performed before the mass. One very interesting method is that combining the lesion-specific CT FFR with microvascular modeling and simulated perfusion. So theoretically, you can calculate the CT FFR, myocardial mass at risk, and myocardial blood flow. So previously, CT simulation can provide only CT-derived FFR value, but now it can provide the myocardial flow and also the myocardial territory. So this is a kind of a one-in-one solution for the whole assessment for coronary artery disease. However, we have to understand that the myocardial territory is different from the myocardial ischemia, so that the percent myocardial ischemia can only be assessed by the myocardial perfusion imaging. So here in this vessel, there's 15%, and here, even it looks big, the territory is only 5%. However, this also has limitation because this can be assessed retrospectively. We cannot do it when we decided to do a procedure or not. One more complicated thing is that the discordance exists among anatomical territory, ischemic territory, and prognostic implication. So here, after stent implantation, big single diagonal branch has been occluded. So from the visual estimation, it seems to supply 15 to 20% of whole myocardial mass. So it should cause symptom, ischemia, infarction, regional wall motion abnormality, arrhythmia, valve dysfunction, or the serious problem. However, if you see this MR scans, you cannot find any regional wall motion abnormality, and occlusion of this branch caused a heterogeneous delay enhancement. So there should be a mixture between combined infarct and non-infarct myocardium. So even it looks very significant in anatomy and ischemic territory, its influence on symptom, regional wall motion abnormality, and all subsequent elements for this vessel significance is different. And also from the angiogram testing, you can see the discordance among these three elements. So here you're looking at two big diagonal branches which were functionally significant. So when this branch was isolatedly occluded for 1 minute with balloon, the response was different. So above case, upper case, occlusion of that branch caused severe chest pain and ST segment elevation in 12-lead ECG. However, in the lower case, the patient didn't complain chest pain and there was no ECG change. It's because that the patient's collateral recruitability was quite high, with the wedge pressure of 39 millimeter mercury. So in summary, identification of significant side branch should be the first evaluation step for bifurcation lesion. And we have many tools to assess myocardial territory or ischemic burden. However, each modality still has its own strengths and weaknesses. And for all branches, we know that ischemic territory is smaller than estimated myocardial territory. Furthermore, discordance exists among anatomical territory, ischemic territory, and prognostic implication. Therefore, my conclusion is we definitely need further studies to define significant side branches. Thank you very much for your kind attention.
Thank you for being with us today. Maybe we have a question in the audience. Yeah, Patrick Seris.
So you quote Charlie Taylor, his last paper with Panapolis in the Annal of Biomedical Engineering showed two things: that you can measure the absolute volume, flow volume in this territory, but also that you can measure the resistance. So in other words, you can have the IMR. So is the IMR also a disturbing factor? Because you mentioned collateral, you mentioned some predictivity of but I think IMR can be one of them, no?
So Patrick, your question was that the resistance issue or all the other issues related to this complexity in AI, maybe. So I agree that with your collaboration with the HeartFlow team, it's very nice to see that you're working with the microvascular resistance and all those complex interaction. So while working with the significant side branches with the other engineering team, I found that we still need more information to teach the machine to do a prediction for the significant side branches, because there are too many things we do not know. For example, resistance influence, and also that we understand that the myocardial fiber structure is different between septal and anterior wall and lateral wall, so that there are many things we have to teach the machine so that the AI can help us for defining the significant branches. So we are in I personally think that we are in the beginning stage, so that when we had gathered further information from any element of the coronary artery and myocardium, so we can get better. And I think this AI session can be a kind of a first step for that target.
Another short question, very short, is do you believe that the intracoronary ECG can be useful? We published a few years ago, and I was sometimes impressed by the discordance between the superficial ECG not showing anything and the intracoronary showing that. It's not so difficult. You just scratch the baseline of the guide wire, and you have a beautiful ECG during your balloon occlusion, yeah?
Right, so I think that's also a very interesting methodology, so that we once did it for all cases with balloon occlusion, and my lesson from that using from intracoronary ECG was it's too sensitive, so that most small branches occlusion have, because it's very sensitive, it represents the local electrical disturbance, and I personally feel that even if intracoronary ECG, it shows ST segment elevation, unless we find a surface lead ST elevation, it may be a too sensitive index, but we still need further information about that. But it's an interesting methodology, and it can be done easily in the cath lab, but I still do not clearly understand the clinical relevance of that finding in daily practice.
Hi, Kwon, this is Carlos here. It's a practical question. So now we're facing that most of the patients coming to the cath lab have already a CT performed beforehand. And we have these tools like the Voronoi algorithm to help us calculate the vessel-specific mass. And we are now in the cath lab with this number saying this diagonal have 10% of the left ventricular mass, 5% of the left ventricular mass, and we really don't know what to do with that number. do you have a practical advice on from this amount of mass subtended by the diagonal of a marginal, you have to do this or other thing from the technical point of view?
So, I think that's also another important question. So that currently most AI technologies are using to define, CT-derived mass estimation. But as you just mentioned, that kind of estimated mass is generally much, much larger or higher than true ischemic burden, because we know that the 10% ischemia is not from CT scan or not from mass, but from the myocardial provisional imaging, which really shows that the ischemic territory. So that what I know for sure is that the CT-derived or any AI-derived mass estimation is much larger and exaggerating the ischemic territory. So that I think we have to increase the cutoff for the significant branches, but as you just mentioned, which is really significant branches, 10%, 5%, 15%, I think we need more data for that, because for that significance, we have to integrate the prognosis, but unfortunately, we don't have enough data for that.
Thank you very much. It's an extremely important discussion, and I'm so happy that you also feel that we're just standing at the beginning, but this is actually the start. So we need to actually work together and collaborate together on moving forward. But I hope you will stay maybe to participate a bit in the discussion for the rest of the session, but we will move forward with the next presentation, which is dedicated to how to treat or not treat a side branch and how to make that decision, given by Maciej Lesiak. And Maciej, you may be present virtually, but we will run the video now.
Hello everyone, and thank you for the invitation. I was asked to give a talk on how to decide to treat or not to treat the side branch in the provisional stenting. This is my potential conflict of interest. So I think that the answer to this question is not easy because of many reasons, one of which is the various mechanisms of side branch compromise, like plaque or carina shift, spasm, dissection, or thrombus formation. Then, of course, the question which side branch is clinically relevant. We just could have heard the good talk on that. And actually, what is a suboptimal side branch result in provisional stenting, and does it have any prognostic clinical impact? And finally, what is the best side branch treatment strategy? Is it the combination of balloon techniques like FKB and POT, or perhaps side branch bailout stenting, which varies from 1 to 42% across different clinical studies? The consensus of EBC gives a definition of a significant side branch as the one that operator does not want to lose. And I have a problem with this definition because sometimes the operators just don't care. So that's one of the example, a case performed in one of the big Polish cities this year. You see the anatomy, this is the stent, and that's the final result. And believe me or not, the operator considered the result optimal and left the patient with this occluded diagonal branch low. We have a couple of definitions of suboptimal results on angiography, starting from TIMI flow less than 3, then TIMI flow less than 3 plus some diameter stenosis, more than 75% or 50% fall at main, etc., etc. On top of this, we have some 3D quantitative QCA definition, and finally, physiology. But actually, physiology does not help, at least we know this from DK Crash 6 study, where both angio and FFR guided group fared exactly the same after 1 year observation in clinical terms. So no any help with physiology. So I think that's the honest statement of the consensus, that definition of optimal side branch result has yet to be established. What actually we do know, so first thing we know is that if you lose a sizable side branch, it will translate into clinical outcomes. So these are data from 100 patients undergoing elective PCI with no normal pre-PCI troponin levels. And you can appreciate that if the increase of troponins is more than 5 times upper normal limit, there is a penalty in mortality. So there is at least actually a linear correlation between the increase in troponins and survival. So definitely losing a sizable side branch is really dangerous for the patient. So do we need to touch a side branch at all? So these are data from COBIS-3 registry published this year. 1,600 patients with simple crossover stenting and 500 patients with side branch opening. So this is a side branch opening group. And after 5 years of observation, the authors found absolutely no difference in clinical outcome in target lesion failure. And interestingly enough, on the right-hand side of the slide, you appreciate a target lesion revascularization, which occurred really low in both groups. But strangely enough, in a side branch opening group, the side branch related TLR accounted for almost 2/3 of all TLR cases, whereas in the no-touch group, it was only slightly more than 50%, where the side branch related TLR accounted for all the TLR. So this is a really strange result. And in another registry published this year, this is the data from E-Altimaster registry with more than 4,300 patients observed in this registry after propensity match. You can appreciate that it was POT that influenced significantly the clinical outcome. So this is the cumulative incidence of the events, whereas the use of kissing balloon technique did not influence the adjusted TLF at all. So this is my simple approach to the side branch after main vessel stenting. So for non-left main lesion, if the result after crossover stenting is TIMI-free and side branch diameter stenosis less than 75%, I consider a PCI optimal and finish the case. If TIMI is less than 3 or side branch diameter stenosis more than 75%, I touch the side branch. I do kissing and repot. And then if there is a TIMI-free with any side branch stenosis and no major dissection, I finish the procedure, and TIMI flow is less than 3, or there is a major dissection, I stent the side branch. As for the left main lesion, is exactly the same, but my threshold is slightly below. So this is not 75% by 50% to consider PCI as optimal. And finally, we have to wait, I think, a couple of months for the results of the October study. 1,200 patients randomized to OCT and standard guiding technique, which is angiography and IVUS. And I just checked on the Twitter and found that 3 weeks ago, it was only 70 patients to go. And so I hope that soon we'll know the answer whether OCT helps in bifurcation guidance. Thank you very much for your attention.
Hi, thank you very much, Maciej. It's Olivier speaking. Yeah. Maybe question in the audience, or maybe I've got a question. I'm totally agree with your flow chart for touching or not after provisional standing. But don't you think that if we know before the procedure what is a real myocardial mass concerned by the non-left main branch, side branch, for example, or if we know before what is the real ischemic territory of in terms of side branch, we'll be maybe more cautious about the result after main vessel stenting and not leaving less than 50% of residual stenosis.
Yeah, that would be really very useful, but in both ways, So from the one hand side, we will be more careful and take more care about, side branch sizable side branch, but on the other hand side, knowing that this diagonal, for example, is not clinically relevant and supplies no big territory, perhaps we just leave the wire to protect and leave it open after the procedure, without much attention to the final result of the. This is what we actually do with very small side branches. So I think that definitely that's one of the very important questions. We still don't know exactly how to evaluate the not only the ischemic burden and the supply area, but also clinical importance of the side branch. And what I showed, one of the good example of troponins rise. If you have a troponins about 5 times the upper normal limit, it will translate into more high mortality. So this is really important, I guess.
Yeah, Manuel, question for you.
What do you consider a major dissection at the side branch in order to stent or not to stent? Could you be more precise?
Yeah, of course. It's more like my gut feeling than any definition. So of course, any flow limiting dissection is major. But I mentioned that if there's STEMI free and no major dissection, which means that of course it doesn't go. So to me, it's when I see the staining of the contrast after injection and for longer time, and I clearly see on angiography dissection free or C or more, then I consider it significant. And if the vessel is sizable, then I cover with stent. Otherwise, sometimes I use the prolonged balloon inflation if that's one of 2 or 3 diagonals where I know also from the studies from our Korean colleagues that perhaps the territory supplied by this vessel is not very high. So this is something we need artificial intelligence, I guess, because that's more than my gut feeling and really some criteria, very strict criteria.
Thank you. Maybe Jens.
Yeah, well, but excellent, Maciej, because this was actually my question. Where do you think we need artificial intelligence for? And so this is the unknown unknowns, right? Yeah. Thank you very much, and again for setting the scene for how to move forward here. And I hope that you'll stay in touch with us during the rest of the session to be able to discuss. We're moving forward now with the next presentation, which will be from Tom Johnson. And now we're moving into imaging and how do we see the place for artificial intelligence in imaging and how to evaluate the result in the frame of bifurcational treatment. So if we could have the video from Tom.
Dear Chairman, thank you for the invitation to present at this year's EBC. My talk is entitled Intravascular Imaging and Artificial Intelligence, How to Decide When and How to Use It, the Present State and Future Trends. These are my disclosures. I think firstly we outline what we really mean by artificial intelligence, and the overall umbrella term really focuses on a program that can sense, reason, adapt and act. Beyond that, then we drill down into machine learning, where there are algorithms whose performance can improve our understanding of data, and then even more so, deeper understanding of these large data sets with the use of multi-layered neural networks can further enhance our utility of data. And in fact, already we have elements of all of these at play within intravascular imaging. And I thought, firstly, I needed to challenge the question that's been set to me, because to decide when and how, I think, opens up a potential problem here, because the when offers up this interaction with human intervention, and that could pose a problem. Now, clearly, we're awaiting the outcomes of trials such as Illumian 4 in October, which may well guide us very much more on the when, but I think for the moment it's important for the purpose of this presentation to focus on the how we may use intravascular imaging and AI. In the present state, we have co-registration across a number of different industry tools, morphology through the most recent Ultron, but also through virtual histology IVUS and the use of NIRS IVUS, vessel dimension support available now through Ultron, bifurcation software with both Abbott and Terumo, and then stent optimization, which in my mind, I think is currently best undertaken with the Abbott software. And I'll highlight examples of this using an Ultron case. So this is a complex left main that I had as a recorded case with significant LAD disease, extending from left main distal through into also an angulated circumflex. Co-registration here by OCT actually offers us a much better understanding of what's potentially ambiguous angiogram. If we then overlay on that morphology, here we see with a threshold of 60-degree arc of calcium using this new Ultron AI software, the ability for us to detect calcium throughout this circumflex vessel. Now, we may want to increase the sensitivity, so we look at a 180-degree arc, which may be clinically more relevant, and we see actually that there's relatively short segments of calcium now within this circumflex vessel. We compare that against the 60-degree assessment. Actually, then that poses a difficult clinical conundrum because here we have a horseshoe of calcium, slightly underappreciated by Ultron here. It's saying 187 degrees. It's probably closer to 220 degrees. And then really now the question is, do you take a non-compliant balloon, a cutting balloon? Should we up and debulk with rotablation or CSI? Should we be taking IVL? And I have to say I'm not sure, and we'll hear people with very firm opinion. But the reality is machine learning and observing the decisions we make and the outcomes that we achieve may well facilitate for us a far more enhanced decision-making process. Beyond that, I think there's also a cautionary note, which is this is the example of the pullback actually down the same patient's left anterior descending artery where I failed to clear the vessel of blood, and we see lots of red delineating a question over the quality of lumen demarcation. And if I overrule that, again, a human intervention, then actually we start to see recognition inappropriately of calcium to a point where, had we been led by the machine, we may take more advanced adjuncts such as IVL here to fracture what's said to be 317-degree arc of calcium, where in fact there's no calcium at all. So we must be sure that we react to an output that is from a good quality input. Now, beyond that, then we might start thinking about the stent. And this is a lovely anecdote given by a colleague in London, Richard Bogle. Would you actually buy a carpet from a bloke who stood in the corner and said, I think you need a 4x23 Axminster there for you, sir? The carpet's not going to fit. So we need precision tools in order to ensure that we make the right decision. And we now have available this co-registered ability to select where we want to land our stent by angio, but then also by assessing our proximal and distal landmarks. And here now we have recognition automated of the external elastic lamina, which was very poorly achieved by human method in Lumion 3. The next decision, though, then is the bifurcation strategy. Now, I make a decision due to discrepancy of vessel caliber, angulation of the circumflex to do a DK crush. But actually, it may be that through the assessment of the geometry, the assessment of the tissue, that actually a machine may tell me different in simulating the different techniques that could have been used in this bifurcation. The next step following stenting and optimization with ballooning and wire cross would be to use bifurcation software. Here an example using AptiView. Ultron sadly at the moment doesn't have bifurcation software available. And again, we see from the beautiful consensus led by Yoshi and Numa that there are a number of different potential scenarios of where our wire could cross. But a machine, again, may assist us in making that more nuanced decision. This is the angiogram. Looks good. It looks good, I say, but can we be sure? Really, we have to move on to take the OCT. So here is the OCT taken down the LAD. The white lines tell us immediately no malapposition. We can turn then to look at individual segments, again through human interaction at this point, but this may become automated in the future. We have an MSA of 16 proximal, and then using the Lumion criteria, half and half, proximal half 6.5 MSA, distal half 4.6. So we're happy. We could use tapered mode, and here we see actually again an MSA of 4.6 in that distal third of the LAD, but no evidence of underexpansion below 80%. All automated. We also highlight areas of malapposition which are not adequate, so there's the requirement to go back and further optimize with further ballooning and recross into a side branch. This is the final result.
As an MSA in the left main.
Just for the purpose of speed, I'll show you those results. And geographically, we see a very nice result in the LAD in the cranial view, and we see a very nice result in the caudal projection for the circumflex here in the spider. So what does the future hold? Well, there's some really exciting technologies available. This was recently published in Neurointervention from a Chinese group here highlighting enhanced tissue characterization, being able to delineate lipid, fibrous tissue and calcium, and then also superimposing a remodeled vessel contour for the purpose of achieving an OFR ischemia assessment, maybe both pre and post stenting. Beyond that, we've seen the incredible advanced simulations led by Yiannis, Chatzizisis in Nebraska, and the potential then for us to model different scenarios of bifurcation, also limited by the potential soft or stiff nature of the vessel according to the tissue characterization by OCT. So that hope that we might actually have a machine that could tell us the most optimal bifurcation strategy could become a reality soon. So how to decide when and how to use AI? Well, I think we have to reflect that we have the potential both to make or destroy these technologies, and that's mainly through our ego potentially overriding or driving decision-making. We have to let the machines take some of that control, but there is clearly an interaction. Machine learning provides a really exciting potential. We have the potential of calcium-based algorithm decision-making, a bifurcation strategy decision tool, the potential for AI-guided optimization. But success will absolutely depend on our intelligent engagement with these technologies. I thank you for your attention.
Thank you, Tom. Thank you very much for this wonderful demonstration of what will happen in the future with intracoronary imaging. Wonderful. Yeah, Patrick Serres, one question?
Beautiful talk, Tom. I think the challenge is huge, because in the first place, to feed the machine learning, you need a big database. Take, for instance, the program of Sanven 2. He put together 3 core labs, including Chico, which is here, to get enough judgment by the human brain, because it's just that. It's the human being has said, I think this is calcium, I think this is crystal, I think it is foam cell. And by accumulating the same pictures, finally the machine recognized this signal. But still it has to be challenged by specimen and so. So big data is the first step. What is difficult here is that you mix diagnose and treatment strategy. So it's really 2-step. So not only you need big data for the recognition of the pictures of the OCT, but then you have to see in all these trials what is exactly the strategy which work. You can use simulation, but simulation is not the interaction between your OCT and your simulation. Can be. The last papers are always a little bit in that direction. So I think it will take time. But the first thing I think is big data. Yeah. I think you have to work to big data. If you could, especially for the treatment strategy, you have to know which is successful. And of course, all these trials, with all the respect for the investigator, are always a little bit biased. I want to prove that the DK crush is bad. I want to prove that the provisional is bad. So it's where is the real truth is always a little bit tricky. You know, we are all investigators who must be right. I must have the best technique. So that will be another challenge. Yeah.
Thank you very much for opening a very interesting debate. Maybe
it's regarding the algorithm for calcium. I think it's Napoleon said, no strategy survives to the battlefield. In the meaning that you can plan your battle, your initial strategy, but then the battle evolves in a completely unexpected way, and then you have to improvise, to update your strategy to the real situation. And my feeling is that in interventions with calcium, it applies perfectly, because you can plan an initial strategy, but then you don't know whether this strategy is going to work, etc. And I see like a huge effort to decide the initial strategy, but probably this will not give us the 100% answer. So you need a natural intelligence adjusting the intervention to the real scenario. This is my perception. I wanted to share with you.
Juan Luis, it's lovely to hear from you. I'm sorry that I'm not with you, but I agree with you completely. But I do think, as I said in my first kind of statement of the conclusion, is that we're at greatest risk of destroying this, and I think often our bias overrides our intelligence, and I think that's been particularly evident in the space of calcification, where we've seen new modalities and an excitement about having a new modality, and then all of a sudden that becoming the only solution. And so absolutely, kind of then leading back to Patrick's first statement, is that we need to gather big data sets in order to then be able to predict the most likely outcomes. But in some of that's about us releasing control. And I think as a group, we also have to reflect that interventional cardiologists are probably some of the most controlling individuals that we're ever likely to encounter. And so again, we're faced with more challenge. For me, I think the whole thing is fascinating because it does really reflect back on us more than the limitations of the technology, really. I mean, in terms of the data, it'd be very interesting to hear your experience from the data that was published most recently with your intervention, because actually I was most struck by how closely correlated the 3 core lab groups were in defining the tissue types. Clearly, the areas that we thought were most likely to be challenged, like lipid and macrophage, that might be misinterpreted between individuals, but I think the R was still 0.8, 0.86, something of that sort. So it was still very strong in terms of the correlation between core lab groups.
Again, an extremely important discussion, and we pick up all these meanings and insights because we are at the start of this, and of course our intelligence can ruin the artificial intelligence. So, well, I know you have the final remarks later, so I think you'll stay with us for a bit more. But now we'll move forward to Francesco and discuss if it's possible also to actually make prediction of which technique to use, coming back to all the other discussions we have had. But let's see the video.
Ladies and gentlemen, Mr. Chairman, I'm Francesco Burzotta from Rome, Italy. These are my conflicts of interest. I would like to start remembering the fact that bifurcation stenting techniques are a growing and confounding family. The first who wanted to push to fight against the confusion was Yves Louvard, and he was the leader of a consensus document in which the concept was to recognize that in bifurcation stenting, you may start with a plan and end up with a different conformation of the stents. The final appearance was the creation of a MATS classification, which is based on the position of the first stent and also on the number of implanted stent following a dedicated sequence or not. Can we have now more than MATS? Well, after more than 10 years, some techniques have been abandoned. The value of ballooning technique like pot, kissing, side branch relations, and their sequence of application has been strongly recognized as important factor, and some dedicated devices became popular. So there was a strong reason to try to update the stenting classification, and the white paper came out on 2020, having the revision of the MATS classification with the MATS 2, which has been updated. There were key technical principles to guide the clinical practice inside. Indeed, crossover stenting, sized 1:1 according to distal main branch, followed by pot, has been recognized as the minimal treatment for any bifurcation. Kissing balloon inflation has been recognized mandatory only and for all 2-stent techniques, and also regarded as an index of technical success, since the performance of final kissing is probably more important than two-stent technique selected. A family, T-tap and culotte, can be effectively considered to implant two stents anytime risk of side branch occlusion is not high. On the opposite, as with DK crash as the correct sequence, but also inverted A, inverted culotte, inverted T-tap, can be electively considered to implant two stents anytime risk of side branch occlusion is high and the operators decide since the beginning to implant two stents. So we have, we did a step forward in the understanding, but is this enough today? I think that when you have a situation like that, we didn't solve many doubts that the operators may have to use or not imaging, how to predilate, to use or not debulking, how to implant first stent and how to end up in this kind of patients. And this is why there is room for improvement and welcoming new technologies that may help our practice when we have complex questions. In this regard, artificial intelligence is coming out. The definition of artificial intelligence is the use of mathematical algorithms which give machines the ability to perform cognitive functions such as problem solving, object recognition, and decision making. So all of these aspects can be incorporated in the improvement of treatment of bifurcation PCI. For example, if we aim to describe bifurcation anatomy, we know that it's not easy task. And if you start from angio, we recognize the fact that there was a strong improvement in QCA bifurcation algorithm that are actually used in trials. However, the automatically detection of bifurcation lesion anatomy based on deep convolutional neural networks is a reality that has started to build. Also, invasive imaging may gain something from it. We know that if we have an image, we may take time to have appropriate analysis of the images. We may look forward to have a deep convolutional network for automatic OCT plaque characterization. And from this, we may expect that the time for analysis is strongly reduced. And we may also look forward to learn from images like that, processing that allows us to really understand the plaque anatomy that may also be helpful in procedure planning. Other aspect is the hope to simulate bifurcation stenting using patient-specific data. And I think that there are several groups represented at the EBC during these years that really worked hardly in this direction. And this is a recent review showing how it is now possible to reconstruct before and after PCI the anatomy, especially integrating angiographic analysis, 3D-dimensional reconstruction, and OCT imaging, so that we will know a lot from it. And on the basis of these images, computers may start simulating different techniques from patients' data. So identification of patient-specific optimal stenting strategy is what we ask for, but also reduced need for bench and animal research, stent design and mechanism and mechanics optimization and educational tool may come together. Other aspect is to predict events by processing big data. So we know that we may learn from the integration of imaging, clinical aspects like ECG, clinical presentations and labs, and all together might be processed to generate pre-procedural risk of adverse events stratification, integration with cognitive computing to support clinical decision-making by selection of management strategy, intraprocedural monitoring of multiple data, and personalized models of therapy like dual antiplatelet therapy length. So last aspect, probably, more easy to be captured, especially for educational aspect, is a better visualization of imaging. And I really am starting doing it with some companies, and we will see in the future much more. Thank you very much for your attention.
And thank you very much, Francesco. We know that you are participating in the session in the other room and you are not present. So just keep the presentation here in mind. And I think that what we have seen now is a lot of, well, emerging questions. We need big data set to make proper quality data. We need good definitions of outcome to compare the huge data set to the outcome to make a good learning process. We have differences in interpreting pixels in pictures and translate that into information, data mining in text and figures, numbers, time, learning over time and not in specific data sets. So there's a lot of actually modalities we have heard at the discussion until now. And that definitely call for a plan. And that plan could be, how do we avoid to have total different languages when we are discussing artificial intelligence? And that leads me to the final presentation of this session, which is actually a way to look at how do we standardize the way we do the different trials, do the different building upon each other things, and how is the standardization and the validation of the new technique. So I think we should run the next video, artificial intelligence, machine learning, convolutional neural network, and so on by Professor Tinen Iles. And Tinen is present in the panel, so I think it would be very easy to discuss after that.
Thank you so much for the invitation to present at the EBC 2021 meeting. My name is Tinen Iles, and the title of my presentation is Considerations for the Use of Artificial Intelligence, Computational Simulation, and Prediction Algorithms when Supporting Clinical Decision. In this talk, I'd like to propose that we open a collaborative dialogue and evaluate how models and algorithms are used clinically and find a common language and framework for that evaluation. And specifically in this meeting, how AI and numerical methods, computational modeling, risk assessment and prediction, translational engineering relates to the treatment of bifurcation lesions. And also to recognize that when algorithms are informing clinical decision-making, that it is considered to be software as a medical device. And for SAMD, there is, of course, validation of the actual code, but then also validation of predictive measures that the algorithm claims. So for instance, if a software claims that it can predict restenosis, then it would need to be validated for that outcome. But when we start to think of all the complexities from tools in AI and when making these clinical decisions, we need a foundation for how we are evaluating both the regulatory perspective that contributes to this body of evidence for improvement in patient care, and also to establish credibility and improved patient outcomes. And I think it really starts by taking a high-level look at the tools and see how we can work together. And there are varying levels of model-informed clinical decision-making, and some models can help to guide procedural development, and others are designed to make a precise decision or prediction. Here are 3 specific projects that provide kind of more of the base translational knowledge, and then that adds to the body of evidence, but are not really validated based on outcomes, but are meant to support ideation around the procedure and provide information about the resolution of the model. And the first is an algorithm for detecting adhesions during lead extraction. And this is patient-specific. So you take a patient-specific model, you can look at a heat map for where you might have issues when doing the extraction and be aware of that. And it helps with the procedural planning. And the second is simulation on VA ECMO. and the occurrence of north-south syndrome. You can simulate the cardiac function over time, and you can evaluate that in a simulation from a cadaver, as well as comparing that to a patient to help to make a decision. And the third is comparing the velocity of differences in computational models that are smooth versus those that include really detailed trabeculation. And these are compared in order to evaluate how much that detail actually affects the overall simulation. What are the next marked steps or tools that we can utilize for scaling this for higher impact? I would like to advocate that we need artificial intelligence to effectively capture outcomes in the databases and also in clinical imaging, and that we need simulation and other numerical methods that may be standardized or patient-specific. And also we need to pair outcomes with those clinical measures. And we need to establish verification, validation, and uncertainty quantification as part of the regulatory process. And this is really leading to consensus and established credibility and prediction of outcomes. So first, let's look at the use of AI simulation and pairing this with outcomes. This is a simplified framework for how we can use multiple tools synergistically. And there's a huge toolbox in artificial intelligence and machine learning, and also in computational simulation and numerical methods and models, and how we can both relate this to outcomes and how this can be used for prediction. And there is prediction in all of these areas, and the overall prediction of outcomes relies on the resolution of the micro predictions from each of these nodes. And for instance, the simulation predicting the physiologically accurate state. And as an example, I'll use an imaging example, that if you're using AI image recognition software and we need to avoid overtraining a network so it doesn't memorize an image and then kind of feed that back. And in this technique, there's a situation called model collapse, when you are training a network not to have it actually memorize the medical images from a realistic image. And you can use techniques such as adversarial neural networks, where you're basically seeing if you can trick the discriminator of that network. But in order to achieve this synergistic model, I think we need to acknowledge the engineering concepts of verification, validation, and uncertainty quantification, along with the standardization within the regulatory pathway in order to have a common language and also to reach transparency in what the models can and what they can't do. So the American Society for Mechanical Engineering has a subcommittee that's dedicated to VVUQ in computational medicine, which is the VV40, and also in our artificial intelligence, which is the VV70. I'm on the committee of the VNV40, and I'm also in a working group that focuses on patient-specific modeling and the global alignment of the regulatory bodies, including the FDA and IMDRF. And from a benchtop engineering perspective, the validation and verification for a stent is relatively straightforward. There is a specific loading condition. Maybe you're measuring the atmospheric pressure of a balloon can tolerate before failure, what will equal a given size, et cetera. But the challenge is when we bring in simulation, it is to validate pairing indirect measurements. And for example, increased level of vortices at the carina being a surrogate measure for the risk of thrombus. It is more difficult to establish the confidence in that prediction because of this. So this top flowchart is used as a key to develop BNB activities and how we can actually support the use of computational modeling. And this is a really oversimplified example, but this is just to get across the point of how we can come up with this framework in varying different types of activities, and even using kind of like the MADS classification as part of how we direct these VNV activities as well. So first we start with the question of interest. Should I put in one stent or two? And again, there can be several questions and contexts. Questions of interest and context of use. Maybe the context of use is an acute case with a bifurcation lesion. And then we also need to assess the model risk. How much am I relying on a model to make the decision of one stent or two? If I create a model, and I can look at this on the bottom right-hand corner, there's a model risk matrix. So how much is the model influencing, and what's the decision consequence? If I'm using this maybe for ideation, like I run a simulation to see what some of the turbulent flow patterns are, a patient-specific model, If I'm just using that to get a general idea and if the decision consequence is fairly low, then you can be on the bottom left-hand corner. But if I'm making a specific decision on one stent or two, and maybe what pathway or the validation of it being properly placed, looking at recoil, having these more specific questions, and that the decision consequence could be very high, then we could go up into the top right-hand corner. And this is a very simplified model risk matrix, but this is an example of how it gets to be very, very complex very quickly. Next, we need to establish the credibility walls. When is this model credible? What information do I need to add? There's going to be a body of evidence with multiple trials, multiple different outcomes, but when are we going to be done and when is it going to be established? That helps us to understand how we can execute a plan for that. And this may require significant database analysis paired with outcomes. And what is the computational model? Are we relying on previous computational models from other patients or similar patient populations? Or is it patient specific in a case? And so then we have to ask the question, after we kind of run all these V&V activities, is assessing that credibility and look at the documentation and evidence, and that each one of these studies really adds to that. And this is all from the ASME V&V 40 publication, and I'd be happy to provide as well. But here's another figure that I really like from this documentation, and that helps us to see the different context of use and how that relates to the different validation points. Like perhaps software is validated to answer a certain context of use or a certain question of interest. And there could be contours of different levels of confidence for each one of those contexts of use, and decreasing levels of confidence depending upon what that context is. So how does AI fit into all this? And I believe that the use of AI in these steps for extracting and analyzing data and imaging is really how we scale up for improved patient treatment, because it allows for more complex analytics, extraction of data, and solving for the unknown unknowns. Professor Lassen and I wrote an editorial last year where we started to discuss some of these ideas about how we can all collaborate and move forward to establish this with the use of high-powered computing and some of the other future uses of standardization. And we do discuss a little bit on the V&V techniques. So lastly, what is the pathway for established credibility in prediction outcomes? I would like to advocate that this will take a multidisciplinary collaborative effort to support the credibility of model-informed clinical decision-making, and that will require a body of evidence for both general clinical recommendations and also for patient-specific modeling. This first figure is from an excellent recent publication by many of the EBC members that focuses on patient-specific simulation and bifurcation stenting. It's demonstrated high resolution between clinical imaging and physiologic measurements paired with the simulation from the patient. And this type of work is critical to the body of evidence that is needed for validation of the patient-specific modeling. There's also opportunity to harness AI for prediction and applications such as Patient Like Me, where there's a patient profile that informs a predictive model, and the Mentis simulator that predicts biological responses to the operator, also really critical. Ultimately, I believe this can be supported by using supervised and unsupervised tools in AI and machine learning, and capture the outcomes of data that is paired with numerical modeling and simulation. And also to identify some of the surrogate measures of outcomes, the indirect measurements. I think this is really important, and how we can support this body of evidence to optimize model-informed clinical decision-making is also balanced with the art of medicine. So in conclusion, I think we can discuss and explore AI tools and how we can be applied to imaging and to megadata. And there's just a ton of stuff that we can use, and really to understand the tools and how they can be best used and applied, and within the scope of use that's appropriate for the applications, both clinically and for the megadata. And also to identify the unmet needs for the treatment of bifurcation lesions. And we can do this with the use of AI to really understand what needs are not being met and look at different patient populations, and how we can apply tools in AI in a standardized way and with respect to the regulatory bodies. And thank you again for the opportunity to share this perspective on the use of AI in clinical decision-making, and I look forward to the continued dialogue and collaboration.
Thank you very much. Very interesting, but there's a huge amount of work to be in the future. Maybe some comments?
I think we don't realize what Yves Louvard has done for us. You know, these Maths 1 and Maths 2 is an example of artificial intelligence before it exists, because it's a temporal and a spatial resolution. That's point number one. Sorry for the compliment. The point number 2 is collecting data. That's really the first challenge. It is on the slide of the lady with the cartoon of maths. And I've been very impressed by what maths can do for us. In the sense, in the global leaders, 16,000 patients, the largest ever made PCI trial, we put the cartoon of maths. What I was impressed is that that was the first database ready, the first information ready in the database, with 98% correct. Queries was a minimum. So now we have the Maths 2 in multi-talent, same trick. The guys just tick in the chronological order what he has done, and that data will be extremely reliable. But it made me very humble, because you realize that's just the beginning. I mean, you just have collecting what the individual has done. But 16,000 plus 2,600 plus 1,500, at some point we will have, if everybody used that in the ECRF of their trial, very quickly you will have a wonderful basis. But it's just the first step. It is the first line on the slide of the lady collecting outcome, which is not easy. For the compliment, yeah.
For the compliment, but it means I understood that you have an electronic version of maths. Yeah, was my project initially, was our project. I know Francesco is not there, but
for a big registry.
I think will be a very good instrument, because the problem is for the operators is to, even after a tiring case, they have to enter the details of a procedure. So
I also want to make a point here. So AI it creates some anxiety, some fear, because it's something unknown to most of us, but it shouldn't work like that. What is AI, if I can simplify? It's essentially, we have 20 experts here, the best minds in interventional cardiology and bifurcations. That's no doubt, right? So essentially, we take these minds, we integrate them all together, and then we make available this super brain to the scientific community, to any lay doctor who doesn't have access to this conference, doesn't have access to these great minds. So we should not be afraid of the term AI. It's simply integration of experts and then making this knowledge available to everybody. Number one. Number two, we are very lucky in STEM world. And this is general concept in device development, but stents, which is a device, have produced through thousands of patients over the years. Patrick Serraus and many experts here have produced those data, and we're so lucky, and showed clearly that there's some endpoints, some acute endpoints after stenting, let's say expansion, apposition, flow dynamics, which are directly linked to the outcomes. Is anybody against this? No. That's more than obvious. This is not the case with the valves, because we don't have long-term clinical outcomes, we don't have acute endpoints, validated, and so on. But for stents, we do have this luxury. So let's take advantage of this. And what is AI? AI is essentially using this information, these acute endpoints, and tell us, for each particular case, your case, once you achieve the most favorable apposition, expansion, flow dynamics, most likely you're going to have a very good outcome. So the ball now is in our court to find out how we're going to assess the expansion, apposition, flow dynamics in an individualized basis, and then we have the answer. And when we have a case with this tool, which simulations can be a possibility, other ways as well, we can discuss, but with all those tools, we can identify for each particular case what technique, what strategy, what post-dilatation approach, what stent design gives us the most favorable expansion, apposition, and flow dynamics. And then we can very safely infer that that's the best technique, that's the best stent, that's the best approach. And we don't have this luxury with valves or other devices. So let's take advantage of this knowledge that we have produced through all those years and through thousands of patients.
That's the excellent vision. And now we are back to Patrick's statement. We need big quality data. Otherwise, we can't reach the
We have the
vision.
data.
Yeah, well, but we need, But I think we have come to the final discussion in this session. And Tom, would you take over from here and come with your conclusion remarks on the session?
I'd be happy to. Sorry, I can't hear some of what's being said in the audience, but I do see Rodan on my right shoulder. So we've got big thinkers and clearly a room full of them. But I think where we started very nicely was a kind of reflection on the fact that we are just at the very beginning of this. And Yiannis puts it nicely that we shouldn't be fearful, but I think we also have to be mindful of where we are in this process. And Patrick earlier highlighted maybe the need for us to separate for the moment the diagnostic decision-making or capabilities, which may be more at the moment AI and machine learning driven, from then maybe the decision-making that will come thereafter, where maybe we lean more on computational simulation. And then I think Tinen has very nicely kind of highlighted for us the realities that we have and some of the complexities that we may face in terms of software now being considered as a medical device, that there are going to be decisions that are taken away from us, but that we have an absolute responsibility for ensuring the safety and an appropriate outcome for patients. And so I think the first step, and I think maybe we have to take this slow and steady, but the first step is about us focusing on the appropriateness of data gathering and standardization of data, because without standards of data gathering, we're not going to be in a position where we can actually make use and kind of maximize the potential of what we have in front of us. But I conclude just by saying this is incredibly exciting, and it's been a fantastic series of talks which I think have stimulated a huge amount of debate. I look forward to year on year seeing the developments that come from this. So thank you.